Good morning, and thank you for joining us for today's last vertical integration session of the financial year, STIs and BBVs. My name is Sydney Cruikshank, and I'm from the PHN education team, and I'm joined today by Dr. Nadia Clifton, who is the Senior Regional Medical Educator with RACGP, and the beautiful Georgia Page in the house as well. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on the Central Coast, that is Darkinjin land. And I'd also like to pay respect to elders past, present, and emerging. So normal housekeeping things about this session. It will be recorded and available for you to view in our library in a few days' time. As attendees, we will switch you to panelists if it allows you to. I know, Jack, for some reason you never are allowed to become a panelist, so you are there, but I will unmute everyone. Please feel free to turn your cameras. I know we're going to have an interactive session today with Nadia. She will run through that all with you. There is the chat box there for you to ask any questions as well if you didn't want to unmute yourself, as well as the evaluation. We will put the Slido in the chat box for you to click on the link at the end of the session. And a couple little reminders that we will run through at the end as well. We will be breaking in July and coming back on the 16th of August. So that will be our next session. And then if you wanted to put a little save the date in, the 31st of August, we are having our GP registrar dinner. So if you are around, that at this stage is booked for the Arena location. All details will come shortly, but we hope to see you there, and I will hand it over to Nadia.
Thanks so much, Sydney, and thanks everyone for joining us on this chilly morning. Lots of frost around, so hope you're all keeping warm. So thanks so much for introducing me, Sydney. So hi, I'm Dr. Nadia. I'm also a GP and work for RACGP. We are going to be using menti.com today. So if everyone can grab their phones and pop into a web browser, menti.com, and there's a code up the top that I want you to put in, which is 51914908, and that will come up shortly again. And that will just help us to have a bit more of an interactive session as we are online, and it's always anonymous, which is really good. So you can answer without the fear of thinking, oh, my colleagues think that I don't know this. So it's a really good way to give it a shot and for us to have some interactivity as well. And thanks so much, Sydney's just popped the code into the chat box. I would also like to acknowledge country as I am on Aboriginal land, and this is, and an RACGP would like to acknowledge that this is Aboriginal land, always was, always will be, and I'm zooming in from Gadigal land of the Eora Nation, and we respectfully recognise the continuing relationship Aboriginal and Torres Strait Islander peoples have with this land. So what would I love you to get out of today? So thinking about learning objectives, we're going to dispel some myths. We're going to think about how do we ask sexual history, some presentations of STDs, and then thinking about bloodborne viruses as well. So let's do a really quick case to begin with. So I want you to think about this interesting skin lesion and what STD could this be? So we're going to not have this picture on the next page, so I just want you to burn it into the back of your mind. And then I'd love you to head to menti.com, and this is where those questions and you can answer through Menti. And again, the 51914908, and we'll see what we think that STD was. So lots of different possibilities. We've got a couple. Yes, absolutely. Molluscum, definitely. So molluscum is an interesting one because it's not an STD in children, but it can be an STD in adults. So molluscum contagiosum indeed is a STD in the way that it is sexually transmitted from skin to skin around the groin. And indeed, it's molluscum. Why? Because it has that central umbilication of the skin lesions, and usually I'd use something like cryotherapy to zap these out. In kids, I would leave it unless it was causing issues, but it is definitely contagious, even with protected sex. So good work. So let's go on to another quick case to get our brains thinking this morning. So we have a 29-year-old who presents with atraumatic unilateral left knee swelling of 3 days duration. So I want you to think about what could cause this. Could be as part of our topic, but generally what could cause atraumatic unilateral left knee swelling. So head over to Menti again, and I'd love to know your answers to begin with. Oh, I like that. And together, combined, we have Captain Planet. Absolutely. So septic arthritis, possibly from a gonorrhea cause. What else could cause unilateral traumatic knee swelling? generally, if this wasn't an STD talk? Lovely. Gout. Yep. So thinking about our crystal arthropathies. Yes. Reactive arthritis. Awesome. And then just generally a septic arthritis that couldn't be from an STD cause. Absolutely. So if you think unilateral atraumatic knee swelling, sometimes you actually have to ask the sexual health history. And I guess that was the practice point or teaching point for this one. And often signposting can be really important because people are like, what are you asking me about my sexual habits when I have a swollen knee? But absolutely, we've got to think about gonorrhea. And gonorrhea is quite symptomatic. So things like urethritis or cervicitis are going to be some I guess, more symptomatic type presentations, and so you'll have symptoms with that as well. So well done, guys. So let's go to a long case now. We've got Julie. So Julie's a 20-year-old lady who presents to you on a Tuesday morning, and she told your nurse that she has a painful groin. And you start thinking, oh, what does she mean by a painful groin? What do patients mean when they say that they have a painful groin? So I want you to think as broad as possible. What are your differentials? And you could probably answer quite a few of these. When I say, oh, I've had a painful groin, does that mean I've, pulled a muscle? Is it a musculoskeletal thing? Am I thinking it's lower abdominal? So head to Menti and pop in your answers. We'd love to hear from you. And if at any stage Menti sometimes it can be a little bit temperamental. So if you have submitted, maybe just pop in the chat box to let me know that you have. Sometimes it can have a little bit of a wake up and a 10-second lag. I want you to think about your differentials for painful groin in a 20-year-old. Good, so we could think about HSV. Oh, lymphogranuloma, yeah, good. I like those answers. Labral tear, yep, absolutely. Is this more kind of hip? Is there any reactive lymph nodes, DVT? Yep, so whereabouts in the groin are they talking about? Where is the groin when it comes to anatomical? Yeah, okay, great. And then if she means lower abdominal, what else could be going on? So we'll try and get a couple of differentials each. Kind of common things occurring commonly. Yep, ovarian pathology, love that. So got to think about, is this a cyst? Has she had a cyst accident? Has there been any ovarian torsion? Is this thinking about from an ovary perspective? Could this be maybe an ectopic? Appendicitis, absolutely. So where's the groin? Lower abdomen. Great. So I think we have some, yes, and she may mean vulval pain. So what does she actually mean? Yeah. And of course, if this was on the triage notes, if you're an ED, thinking about from a JMO perspective or a medical student perspective, or is this just coming from your nurse? Great. So we've got genital causes, so vulval, we have gynecological causes, ovarian, we've got to think about infective causes, so HSV, PID, inflammatory type causes, appendicitis, and then functional causes, constipation, groin tear, absolutely. We've even got vascular in there. So I guess what's a good way to get a good list of differentials? I use a surgical sieve in my practice all the time when I think, oh, I don't want to miss anything. So let's go broad to begin with, and then the history can help inform me when I target, what the symptoms are. So a surgical sieve that I use is often vitamin C, D, E, F. So thinking about vascular, infective, trauma, autoimmune, metabolic, iatrogenic, neoplastic, congenital, degenerative, endocrine, functional. So going through theirs, vascular, I think we got some DVT, which is good. Infective, we thought about STIs in terms of PID. Inflammatory, we thought about appendicitis. Trauma, Now that's one that we didn't mention. Something when we think about taking a sexual history, there could be sexual trauma, and this can be very triggering for your patient. And I guess we have to be trauma responsive clinicians. So sometimes using a surgical sieve can help inform the way that we ask questions. And so even jotting this down, has this patient just come to disclose to you about sexual trauma, or has she been sexually abused recently and that's why she has a painful groin? So I guess that's my little practice point for using a surgical sieve, because it just helps reframe some of the questions you might have and also the way that you ask those questions. Neoplastic, so I guess we had the ovarian pathology. Could this be an ovarian tumor? And then things like endocrine, functional, probably less so, but functional, maybe constipation, IBS. And then one of the other ones, infective, could this be something like a UTI? So you call her from the waiting room and she kind of shuffles into her room and finds it hard to sit down and kind of does that really bracing as she sits down. And she tells you that she feels unwell with body aches and is worried that she has a UTI, as her friend had one the other week. You take a sexual history, and in summary, Julie has had a new male partner 4 weeks ago and had insertive vaginal sex and receptive oral sex. And she didn't see any lumps or bumps on her patient's face or penis. So this is a very thorough sexual history that you've taken. So I guess going back of how did you get this information and how did you summarize this so well for us? So often when you take a sexual history, it may be daunting. There can be, your patients may be of different ethnic origins, different ages, different sexes as well, or identify as different genders. And so sometimes it can feel a bit awkward. Whenever you have a dialogue with a patient, we'll just run through quick, how do we do a sexual history? Signposting is really important. So telling them that you're about to ask a sexual history before launching into a sexual history is really important. So you might say, I'm going to ask you a few questions about your sexual health and sexual practices. I understand these are really personal, but they're really important for your overall health. And just so you know, I ask this of all adult patients, regardless of age, marital status, gender, and these questions are as important about your physical health and mental health, like other areas as well. So sometimes just giving a broad overview, why you're asking your married 55-year-old with an atraumatic knee swelling, you may just uncover more than meets the eye. Then you have the 5 Ps, so asking about partners, practice, protection from STDs, past history of STDs, and prevention of pregnancy. I often talk about asking their preference. So when this question comes up is, are your sex partners men, women, or both? Well, we also have more than just men and women when we thinking about gender and sexual identity as well. The other thing is that asking if someone identifies as heterosexual, homosexual, bisexual, or pansexual sometimes doesn't always give you the answers. So for instance, I have patients in my practice that they would identify as heterosexual, but they are men who also have sex with men on occasion. So I guess a preference or a label can sometimes also not give you the right answers. So what might be a phrase that you use? You can come up with your own phrases. Often you'll have your own phrases in your own practices as well. A phrase that I often use is, do you prefer to have sex with men, women, non-binary, transgender, or any combination of the above? And then they've got options to choose from that. And then asking about sexual activity. So in the past 12 months, how many sexual partners have you had? And that's, I guess, to give you a risk score. And it also comes to contact tracing, which we'll come to as well. Then you have to get more into the nitty gritty. So in terms of what type of sex, and please use proper language in terms of genital, anal, oral when it comes to sexual type contact. And sometimes again doing a second signpost. So I'm going to be a bit more explicit in the type of sex you've had to better understand your risk, or to take a more thorough sexual history. And that can be quite helpful because you're about to ask, for instance, about insertive or receptive type sex, and sometimes you may need to explain what those words mean as well, and that might be relevant, and we'll come to that when we talk about, for instance, PEP and PrEP for HIV risk as well. And then comes to examination. For anyone with a cervix in the room, I'm sure you've had that awkward sensation of when you're about to have your pap smear and you think, where do I put my clothes? Or do I put the sheet over me? Or what am I supposed to do with, the rest of the equipment? And so sometimes you can be even more awkward as a patient where you feel like you don't have had explicit instruction. So explanation is really important with examination. So for instance, I'm going to have a look at your cervix. I would like you to get undressed from the bottom down. That means your jeans and your underwear. You can put them on the table at the side, and I will give you a sheet that you can then cover yourself. I will introduce myself as I come back into the room or past the curtain. And I'll see if you're ready. So giving really explicit instructions can be helpful. And of course, consent, a chaperone, always offering a chaperone as well, and modesty, considering for different cultural preferences. So for instance, for Aboriginal and Torres Strait Islander patients, there may be something called women's business. So for instance, if you identify as a female and your patient also identifies as a female, that may be okay to do an examination, but sometimes you may not be able to examine if you are of different genders and different cultural practices as well. My hot tip is have all the swabs ready just in case, because you don't want to be, halfway through a speculum and then think, oh my gosh, I need to go get a blue swab or a green swab or a red swab. And so have a little collection of swabs nearby, so you're not running around trying to find it either from, the emergency department drawers or trying to, go get it from your nurse's station when you've got, the speculum halfway through. Always try and do a speculum if tolerated, so that we can see if there is any cervicitis when you're doing a proper sexual exam as well. And so this is what you see for Julie. So you do an examination. This is external vulva. So how would I describe this? So I think we have two lesions, one rather large sloughy type ulcer here, and then one smaller one. So both of the inner labia, so the labia minora, and these are quite painful as well. So it's quite a well demarcated ulceration and a painful ulceration. And so what investigations do you order for Julie? So head to Menti. Anyone who's just joined us as well, just go to menti.com, usually just on your phone or another device, and you just enter that code, which is the 51914908. Sounds like I'm calling out bingo. And please pop the investigations that you would order. So yeah, great. So HSV PCR swab, love that. So very specifically swab. I love that you haven't put that you're going to be doing a blood test for HSV, absolutely. So we don't want any HSV bloods, absolutely PCR. And I love that somebody has also put full STI check. So 10 points to Gryffindor for that one, absolutely. So we want to be checking, she's had unprotected sex. We want to check if there's any other concomitant STIs in particular. Perfect, well done. So diagnosis, usually swabbing the base of the ulcer, and always requires visible lesions to be present. And we never do serology as screening. So ASHM, the Australasian Sexual Health Medicine, says serological tests do not represent definitive microbiological diagnosis and lack positive predictive value in low prevalence populations. There's no evidence-based interventions for asymptomatic individuals who have reactive serology, and antibody results are not specific to anatomical sites of infection. And also 80% of us have been exposed to HSV at some point during our lives. So it could be from a cold sore that grandma might have kissed you when you're younger. So your serology is going to be positive even if you don't actively have the disease. And it could just be that you also have cold sores. Absolutely, and considering other STIs. So let's whip through HSV. So it's super common. 1 in 5 adults have evidence of HSV2 infection, and most of these adults either have a little or very mild symptoms, and some are even unaware of having been infected. It causes lifelong infection and potential for reactivation, and it's a combination of both HSV1 and HSV2 when we think about genital herpes, and I usually think about it being about a 60-40 split. So 60% are HSV2 and 40%, up to 40% are HSV1. And you'll find out on your PCR, of course. It's often very painful. The severity is generally greater than in recurrences. So in men, they might have some lymphadenopathy. So sometimes looking for the lesion, they might have on the underside of their shaft of their penis, for instance, and they might not be able to see it. But when you do a genital examination, you find the ulcer, but they might just come in with a tender groin and lymph nodes being tender. Interestingly, for women, it can mask as a UTI. Why? They get the prodrome, they get the flu-like type symptoms, fever, headache, feeling a bit malaisey, achy, and then they have pain and difficulty passing urine, because if you're thinking about the urine going from where Julie's lesion was, that's going to be really painful. It's going to burn and sting as the urine passes past that part of the vulva as well. So you can also get HSV lesions on the cervix. So again, you might have pain but not be able to see anything externally, and then you do a speculum examination and you can see it on the cervix as well. So if you suspect a UTI but it doesn't completely sound like a UTI in terms of the frequency, or your dipstick doesn't really show much, maybe it shows a little bit of leukocytes, go and have an examination as well. So what's our treatment? Antivirals, of course, and this is taken from ETG, as you can tell by the nice blue box. So acyclovir, famciclovir, valciclovir, which is my preference for adherence, usually Valtrex. Why? It's BD rather than TDS, and if it's a rapid clinical response, you can stop therapy after 5 days, but you should be having the initial first clinical episode should be for 10 days. Again, microbiological confirmation is not required to start therapy, so you would start it anyway as soon as you see a lesion or suspect that it could be HSV. And then for recurrent episodes, interestingly, these can be triggered by lots of things: stress, UV sun, minor trauma, menstrual cycle flare-ups, for instance. It could be a concurrent infection. So if someone's coming to see you for a community-acquired pneumonia, or if you're in hospital and they're in hospital for another type of infection, cellulitis, for instance, you may be writing up the medications for the recurrent recurrent flare-ups, so therefore they'll need antivirals. Normally they're less systemic symptoms, so you're not going to get that kind of flu-like symptoms. They're often smaller, tightly grouped than that original ulcer that we showed you on that Julie's case, and it's often a shorter duration, so they normally go away without scarring. And prodrome, often patients will know that they're about to get their outbreak. There might be a little bit of burning, itching, and recurrences can cause distressingly painful symptoms, or the lesions can go unnoticed and normally heal within 7 to 10 days. And what do we do about it? We can do episodic therapy. So again, pick an antiviral. Usually, famciclovir for 1 day is quite effective. So 1 gram orally, 12 hourly, just kind of nip it in the bud. Or if you're getting lots of recurrences, you may also consider doing suppressive therapy. When might I do suppressive therapy? Sometimes it's for social reasons. So if they're going on their honeymoon, for instance, and they really don't want to have an outbreak. If it's for vertical transmission reasons, so they're giving birth and they need to be on antivirals in their late 3rd trimester, for instance. Or if you're getting quite annoying outbreaks regularly, you can do suppressive therapy. And so suppressive therapy reduces viral shedding and also decreases recurrences by about 80% and halves the rate of transmission as well. So busting the myths. So cold sores aren't the same as genital herpes. No, HSV1 can also cause genital herpes, of course, and it's commonly transmitted through oral to genital sex. It's quite rare for you to get oral herpes from genital sex. So herpes transmission to the mouth is actually quite uncommon. A myth is only certain sorts of people get herpes. No, it's super common. We said 1 in 5 adults, and 80% of us have been exposed to herpes at some point. Anyone who has ever had sex can get genital herpes. And as we mentioned, most people with herpes don't even have symptoms and may not be aware that they have it. And 75% of people who acquire herpes get it from partners who are unaware they have it. So all great news, right? And of course, you may be answering these questions, especially from a distressed patient asking, does it affect my fertility? Where did I get it from? It's not passed via blood. We cannot routinely check it on STI checks. So often they'll say, oh, but I got a clear STD check, or my partner said that the STD check was clear. And one of my favorite resources is the herpes.org.nz. So the New Zealanders do it very well. And they have a myth busting sheet. And often I'll print it out and read it through with my patients. And so that can answer some of those curly questions or questions that they may not think even to ask as well. And often when you first diagnose herpes, it can be very distressing for the patient. They'll want to, consume lots of information and then offer either a follow-up with their GP, or if you guys are the GP from GP registrars, for them to be, book another appointment in a week to come back and say, pop down all your questions and come back to me and we'll talk about it as well. So we might pause for any questions about HSV before we move on to the next section of the talk. So feel free to head to Menti if you have any particular questions, or just pop it in the chat box if it's easier as well. Or unmute yourself, because we can do this very informally. We don't need to, it doesn't need to be didactic. Perfect, guys. So I'll let you pop it in the chat, or just unmute yourself if you have any questions about HSV. Okay, so let's look at another case. Bit of the same, but a bit different. So 20-year-old lady, so Julie's still here. This is new case. She told the nurse that she has low abdominal pain and her obs are normal apart from a fever of 38.1 degrees. So what are our differentials for fever and abdominal pain? So a little bit different this time. What are the main things? What are your red flags? What are your things that you're really considering? So pop to Menti and let me know your differentials. I should have some waiting music for you, but you probably don't want me to sing. Awesome. Love those top three as well. So UTI, PID, appendicitis. Anything else that can cause abdominal pain in a woman of childbearing age, and fever? What else do we have to think about? And I guess with UTI, we could have, pyelonephritis. It could be going up as well. Any other thoughts? Good. Yep. Ectopic pregnancy. Yes. Great. Well done, guys. So we got a lot of the main ones. And we got to think about ectopic. We got to think about appendicitis, UTI, pyelonephritis, PID, and then of course our ovarian. So well done. So we take some further history. So she's had vaginal discharge and dysuria for the past 2 days, and she's in a relationship with a male partner, and she's had unprotected sexual intercourse with a new partner of 1 month, and menarche was at 13, and no previous IMB or PCB, so no postcoital bleeding either. So on examination, her obs are pretty good apart from that fever. And when you feel her abdomen, she has some mild lower abdominal tenderness. So we're not too concerned about appendicitis or rebound tenderness. But we do a speculum examination and it's quite tender for insertion. The cervix is really inflamed and there's some motion tenderness as well. And you notice that there's some discharge coming directly from the cervix, and her urine HCG was negative. So we don't think she's pregnant at this point. So further investigations, we do a full sexual health screen, and it's come back as chlamydia. I would probably do a swab rather than urine, but I just needed to find a urine positive in my own notes to demonstrate this, but I would do a swab. So urine should be used much more for screening as a first pass urine, but swab if you do see a discharge, because it is a bit more accurate. Interestingly, whenever we're thinking about types of PID, we also have to consider non-sexual causes, so things like bacterial vaginosis. So when we do the microscopy, so again, we're doing lots of swabs. Our blue swab, which is our MCS, we've had no growth, and Gardnerella vaginalis is not isolated, and we don't see any clue cells on microscopy as well. And we've got to think, could there be yeast involvement? Interestingly, Mycoplasma genitalium is not detected. in the next kind of 10 years, we're going to learn a lot more about Mycoplasma genitalium. It is a new STD. We don't know much about it. It kind of behaves a bit like chlamydia. We don't screen for it at the moment, but we may check for it if someone is symptomatic. And you can also ask for a first pass urine Mycoplasma genitalium NAT if someone has troublesome symptoms that we keep going through as well. So that's an interesting one to watch this space about. Normally we use like a macrolide to get rid of it, but it has quite a lot of high resistance, unfortunately. So what's the diagnosis for Jenny this time? We have PID due to chlamydia, and PID could be, is this endometritis, salpingitis, is there tubo-ovarian abscesses, pelvic peritonitis? So for those of you guys in the hospital, if you've done OBS and gynae term, you may see that there is a tubo-ovarian abscesses on laparoscopy. It's pretty gnarly, unfortunately. And up to 70% have an unidentified cause, and other causes could be, gonorrhea, could be mycoplasma, for instance, as well. And so how do we treat it? And if you didn't know, where do you go? So the STI management guidelines for use in primary care are really helpful. There's mild to moderate and severe. So if this was my patient who had systemic symptoms of something like a fever, she's probably more going over to the moderate, but I could also consider if we need to do an IV. If she's much more unwell, if she's more tender, I would be sending her into hospital for consideration of admission and IV antibiotics. So metronidazole is going to cover things which is flagyl. It's going to be covering your bacterial vaginosis type organisms. Your doxycycline or azithromycin is going to be covering your chlamydia, for instance, and your ceftriaxone is going to be covering your gonorrhea. So we kind of broaden because we don't always have a cause. And if there's complicated infection, sometimes they need to be having things like washouts as well with PID. So PID is pretty simple. We just got to treat it effectively and then think about contact tracing for chlamydia. So a good website, if you don't already know, is letthemknow.org.au. This website sends anonymous text messages to your partners. So for instance, if Julie wasn't comfortable having a conversation with their partner, or if she's had casual partners on Tinder or something like that, she may find that, oh, I want to just let them know, but I'm not comfortable telling them that it was me. You can send an anonymous SMS from the letthemknow.org.au because it's still patient's responsibility for contact tracing, but it's our responsibility to tell patients that it's their responsibility for contact tracing. And then thinking about how far back to trace. So for chlamydia, it's 6 months because it can be quite asymptomatic. Gonorrhea is much more symptomatic, so we only contact trace back to 2 months. And then always looking up for syphilis, HIV, Hep B, and Hep C, depending on what symptomatology you have and depending on what stage, so primary, secondary, or early latent for syphilis, for instance, as well. Then we might move on to BBV serology. So now we have Brett. So let's imagine you're JMO on an orthopedic term, and Brett, who is a 47-year-old male, is fasting on the ward and is awaiting tendon repair. His father has diabetes. He has no other medical history, no allergies, no medications. His BMI is a bit higher at 31.2 with a waist circumference of 107. And he asks you just on your general ward round, Doc, I'm feeling a bit tired. Do you reckon I could have diabetes? And you think, okay, let's do some blood tests. And this is what comes back. Interestingly, his fasting glucose and HbA1c all normal, so we don't have diabetes. His EUCs and FBCs are normal, but you get this pattern on your liver function tests. So ALT, and this is the upper limit of normal we have in brackets here. So 255 and 189 for AST. Interestingly, Billy is normal. So I would love all the differentials, even the weird and wonderful ones that could cause liver function derangement, and particularly this type of pattern that could cause liver function derangement. So head to Menti, pop in that code, it should already still be here, and I'd love to know your differentials. What could cause this? We want as broad as possible, even the weird ones, you know, that Talia and O'Connor tell us about. Yeah. Good. So iron storage disease, maybe they have hemochromatosis. Could they have alcoholic fatty liver disease? Could they have maybe non-alcoholic liver disease? Absolutely. So what's his alcohol intake? Did I give you that yet? I didn't really go through social history, did I? Absolutely. Yep. So hepatitises, other viral causes. So CMV, EBV, love that. Good. Infective. So we have hepatitises that are viral. What other type of hepatitises can we think about? We'll try and get all of them. Good. Autoimmune hepatitis. Absolutely. Well done. What else? What about some, let's keep going down. Malignancy. Wonderful. So if this is a hepatocellular, could there be a primary malignancy? Could this be another type of malignancy going to the liver? What about some, so we talked about iron storage, anything else that gets stored in the liver? Could be congestive potentially. Yes, Wilson's, absolutely. So does he have, you know, Kaiser flexion rings for copper? Absolutely. And what if he has lung disease? Let's try and have a weird one. What if he has lung disease concomitantly and LFT derangement, which is a hepatocellular? Yes, good. So thinking about sarcoid, yeah, that classic kind of house. So infiltrative granulomas, yeah. And then I'm waiting to see if anyone will get the last little one. It starts with A. If you have lung disease and liver disease, if we're thinking about really broad differentials, it's super rare. So if we can't get it, that's fine. Autoimmune, almost, yeah. Alpha-1 antitrypsin. A bit weird and wonderful. I don't think we ever see it, absolutely, but we got most of them. So this comes up if you just Google abnormal liver test algorithm. I actually have this printed. It's quite helpful just to, again, consider your differential so you're not missing anything. So we have a hepatocellular pattern. We don't think that this is a cholestatic pattern. And then we have to think about what is hepatocellular if our ALT is greater than our ALP. Then we have to consider what is is it mild, is it moderate, is it severe? And mild would be less than 5 times the upper limit of normal. And then moderate is 5 to 15 times the upper limit of normal. So NASH or NAFLD or fatty liver is going to be your most common. You know, up to a third of the population could have some kind of NASH as well. When we have to have moderate, so between 5 to 15 times the upper limit of normal, our most common is viral. So we are about around that 5 times the upper limit of normal. Of course, could this be drugs? We didn't get that one. So what else is he on in hospital? Are we stuffing up his liver? Is this a drug effect? We got autoimmune hepatitis, we got Wilson's, we got hemochromatosis. We didn't get the alpha-1 antitrypsin deficiency, but it's a bit of a zebra rather than a horse. And then we have to think about if this was a young female, are there, you know, HELLP syndrome in pregnancy? Could this be an ischemic event as well if it's very severe? And then could this be also self-harm in regards to a paracetamol overdose? We also have to consider his mental health. So well done, guys. So common causes, we just went through them. Rare ones, we got the Wilson's, less common medications, viral hepatitis, but in this case, this is what we've added on. So his cholesterol profile is normal, his iron is fine, he doesn't have hemochromatosis because his ferritin's 87. He has this in his viral hepatitis screen. And we're thinking, do we do an ultrasound? Maybe we do a FibroScan. And we didn't really do our, you know, next line. We don't do copper and antitrypsin, for instance, or checking for autoimmune hepatitis to begin with. We just have our general screen to begin with. So having a look at this viral hepatitis screen, sometimes interpreting lab results can feel a bit like this, but let's go through what is helpful. So first of all, one of the things you have to ask yourself is, do I have hepatitis B immunity? So your surface antibody tells us if we have immunity. Our surface antigen tells us, do I have hepatitis B infection? Your core antibody tells us if you've been exposed to hepatitis B. So let's go to Menti, and I'd love you to vote of what you think this shows. So we have hepatitis B surface antibody negative, hepatitis B surface antigen positive, and hepatitis B core antibody positive. And again, these are anonymous, so it's good to have a go in our multiple choice. So we're even Stevens at the moment. We'll see a few other ones. Got some good diversity across. Okay. So at this stage, one smart person is correct. It is actually an acute hepatitis B infection. And we might just go back to the previous slide to find out why is it acute and not chronic. It comes into this one. So if we have an acute hepatitis B infection, your surface antigen is going to be positive, but you don't yet have immunity in the way that your chronic, often you'll have your surface, your core is positive in a chronic. And so this is Brett's results as well. So our core antibody here. So hopefully that makes a bit of sense. Also depends on the titer. Then we follow him up a few months ago. For background, Brett has had a new sexual partner 5 months ago, and previous STI screen was negative. This was his initial viral hepatitis screen, and then it's become here. So here we have a resolved hepatitis B infection. So our hepatitis B infection is showing a positive hepatitis B surface antibody. So now he has immunity. He doesn't have an active infection because his surface antigen is negative, but he has been exposed at some point. So his hepatitis B core antibody is positive. So let's move on to hepatitis C. It's quite prevalent. 140,000 people are living with hepatitis C in Australia, down from 230,000 in 2014. And it's quite amazing. In your guys' lifetime, we may eradicate hepatitis C, and we'll come to that as well. So liver cancer and cirrhosis are common complications of hepatitis C, but actually the most common symptom among people living with hepatitis C is actually depression. So we really need to, link them in with mental health services and offer support from a GP perspective as well. And since March 2016, 80,000 cases of hepatitis C has actually been cured due to direct-acting antivirals. Of course, you know the risk factors, thinking about how hepatitis C is transmitted, so injecting drug use, sharing of snorting equipment, vertical transmission through birth in high prevalence countries, blood transfusions, unsterile medical dental procedures in high prevalence countries, needle stick injuries, and sexual transmission in men who have sex with men as well. So for this Menti, we're going to down the bottom, you'll notice that there's a thumbs up, thumbs down, or a question mark. And my question to you rather, is does this person have chronic hepatitis C? So we have a hepatitis C antibody detected, and I want you to give me a thumbs up for you think he has hepatitis C, thumbs down for he doesn't have hepatitis C, or a question mark if you're not sure. Love that. Awesome. It's almost a trick question because we need more information, don't we? We have a hepatitis C antibody detected, but we don't know if this is a past exposure or a present. Hepatitis C is much easier to interpret than hepatitis B. So our hepatitis C test result interpretation, if you have an antibody positive plus your RNA positive, it means you have a current hepatitis C infection. Whereas if you have an antibody positive and your RNA is negative, it means you've either spontaneously cleared or we've treated you. So really this person needs an RNA PCR test to see if they're infected. And then if it's negative, you wouldn't do an RNA, but this is where, part of the table is never exposed to HCV and not infected with HCV. So this one's much easier than your hepatitis B. So this is one of my patients. So hepatitis C was detected, but it's not detected in terms of the viral load. So the RNA was negative and we don't have a genotype. So what are DAAs? They're directly acting antivirals, and they're in their combination oral short course, 95% effective. They're much better than things like interferon that we used to have. We may be able to, eliminate hepatitis C in our lifetime. GPs and nurse practitioners can also prescribe to non-cirrhotic patients, and medical officers can prescribe under the guidance of infectious disease and gastro specialists in the hospital if you guys are in the hospital. So two that are currently available, you've got Epclusa and Maravet. Epclusa, you just take 1 daily for 12 weeks, and Maravet, you take 3 daily for 8 weeks. And so I'll give you an example of one of my patients who was cured. So let's have a look back in 19th of the 6th, 2018. The hepatitis C viral load was 9.06 times 10 to the 4th, and the genotype was 1A. And then we did the short course of Epclusa, and in November, you can see that we have not detected, and then we rechecked to make sure there's no reinfection in February of 2019, still not detected. So this person has completed treatment and we've cured hepatitis C, which is pretty amazing. So we'll move on to PrEP. And our next case is we have a resident on immunology, and we receive a phone call from a colleague who has just had a needle stick injury with a needle while drawing blood from a HIV positive patient. So do we give PEP, PrEP, or TASP? So we'll do the heart for PEP, we'll do the thumbs up for PrEP, or we'll do the little Batman or kitten, not sure which one it is, for TASP. As little reactions on your Menti. So heart for PEP, thumbs up for PrEP, little cat for TASP. What is TASP, you say? TASP is treatment as prevention. Awesome, well done, guys. Absolutely, we'll give PEP because it's post-exposure prophylaxis. So just some background about HIV in New South Wales. From the recently released 2019 report about our annual HIV data, there's 215 new HIV diagnoses in men who have sex with men, with over half overseas born, and 55 in heterosexual people, with 19 being female. And so the number of people living with HIV is currently 28,000 across Australia. You know that it's a single-stranded RNA virus, and of course, thinking about replication, it attaches to our CD4 receptors on lymphocytes, and 90% of people have symptomatic seroconversion. Your antiretroviral therapy or treatment slows down the loss of your CD4 T cells by suppressing the viral load, and if you are untreated, you can get AIDS, so acquired autoimmune deficiency, acquired immunodeficiency syndrome. For transmission in Australia, it's currently only 63% is MSM, and concurrent STIs is a risk factor, intravenous drug use, and perinatal vertical transmission can also occur as well. So this is taken from ASHM. When we're looking, the blue line represents our CD4 T cells. So starting with 1,200 primary infection, at around the 6-week time, we actually get a dip and it does go back up. That dip, your symptoms, you might have the acute HIV syndrome, which often looks like a really bad flu or even COVID. They get fever, myalgia, rash, pharyngitis, adenopathy, often mouth ulcers as well. So HIV is a differential for these cases. And then your red line here represents your viral load. So as viral load goes up after an untreated 10 years and your CD4 T cell comes down below 200, you do get AIDS-defining illnesses such as your, Kaposi sarcoma, CMV infections, toxoplasmosis, and your types of immune-mediated cancers, so lymphomas as well. Then just going back to your case, I guess, what is your risk for your colleague who's taken blood from a known HIV positive source? So this is the ASHM PEP guidelines, really good resource for you to be able to go through when you're doing post-exposure prophylaxis to have that decision-making aid. Now, interestingly, let's just go through some of the exposure. Even with a known HIV positive source, I find it quite surprising that unprotected sex for receptive vaginal intercourse, the risk of HIV transmission is actually still quite low. It's 1 in 1,250. For receptive anal intercourse, if there's ejaculation, it's 1 in 70. And if there's been withdrawal and no ejaculation, it's 1 in 155. So let's go down to a needle stick injury. It's actually only 1 in 440, and this is if the HIV positive person is untreated and a known HIV positive source, for instance. Sorry, this is overall HIV positive, but that includes those that may be untreated, for instance. So it's actually less than 1% that your colleague is going to get HIV if you do nothing at all. And of course, you're not going to do nothing at all. You're going to think about your PEP. So PEP must be started within 72 hours, and usually you have either 28 days of 2 medications or 3 medications, and have a look at your PEP guidelines that are also on ETG. And the window, so most seroconvert within 8 weeks and some are late. So 3 months is the official policy that you need to do your window testing for. So what's window testing is that you're testing at day 0, you're testing at day 6 weeks, and also at 3 months as well. And then all people with HIV should start treatment as soon as possible for treatment as prevention, which is that TASP we were talking about before. So this is taken from ETG. I've cut out the middle section because it keeps going down about the type of exposure. So let's have a look. We have an occupational needle stick injury or sharps exposure, and we need to find out if the HIV positive source, if their viral load is undetectable, or if we have an unknown viral load, or it's unsure, or they're not on antiretroviral treatment. So you'd either use the 3-drug regime or the 2-drug regime as well, depending on this circumstance. If it's unknown HIV status, you have to think about if the source is at high risk of being HIV positive, and you can do a 2-drug regime whilst awaiting test results, for instance, as well. So hopefully that table, even though it seems a bit complicated, we basically find type of exposure, what the HIV status of source, and sometimes it's unknown. So for instance, in sexual trauma victims, for instance, if there has been vaginal intercourse, there may not be recommended unless the source is from either a high prevalence country or MSM, and sometimes it's more that it's unknown. We may consider a two-drug, and if HIV positive but viral load is undetectable, unless it's an occupational exposure, it's often not recommended because U equals U, which means undetectable means untransmissible, refers to the fact that people who take antiretroviral therapy for HIV daily as prescribed and who achieve and maintain an undetectable viral load cannot sexually transmit the virus to a HIV negative partner. So I have a couple of patients who are serodiscordant in the way that one patient is HIV positive and their partner is not. And because they take antiretroviral treatment daily and have an undetectable viral load, it's actually safe for them to have unprotected sex because it is, U equals U, undetectable equals untransmissible as well, which is the wonder of HAART, the highly active antiretroviral treatment. So bear with me in the last few minutes. We've got PrEP discussion. We have, so what is PrEP compared to PEP? So PrEP is your pre-exposure prophylaxis. It's a daily medication on our PBS prescribed by any doctor, and it's taken by HIV negative people, and it aims to prevent HIV infection, to eliminate HIV transmission. At the moment, it's amazing. It used to cost like $1,000 a month. It now costs like $30 a month on the PBS because it's streamlined, and Truvada is our drug of choice. So it's tenofovir, and please don't make me pronounce this one, M-tricotabine. Apologies for my pronunciation. So if you're a GP registrar, if you're a GP, or even if you're in an outpatients department and you're discussing with someone, or maybe you're putting Truvada onto your medical, the med charts in hospital. Talk to me about PrEP. So first of all, who should be offered PrEP? In my mind, anyone who asks for it. But of course, from a guideline point of view, men who have sex with men, trans and gender diverse people, heterosexual people who might have condomless sex with any casual MSM partner, or the serodiscordant relationship as well. For instance, if they're planning natural conception, or with a regular HIV positive partner who is not on treatment or has a detectable viral load. So even if they are taking treatment, if they have a detectable viral load. And Gordon says you may have to use the medication name and not the brand name to get streamlined PBS approval. Indeed, Gordon, indeed, absolutely. And then you have to know how to, maybe you don't have to know how to pronounce it, but absolutely. So people who inject drugs are thinking about shared injecting equipment with HIV positive individuals. So these are the people who may be suitable for PrEP, and it should be a discussion with your patients as well. Then what do you need to do? So there's baseline tests and there's tests that you do at every 3 months as well. And the best resource I can give you is the asham.org, which is the decision making in PrEP. It's a 2-page PDF. If you just type into Google asham decision making in PrEP, it'll come up with a 2-page summary of, you know, who needs PrEP, and what do you need to do in terms of your investigations. So of course, at baseline, we need to do HIV testing, and then we want to be checking your hepatitis, so your other BBVs, so Hep A serology, consider vaccination in primary care, and then your hepatitis C serology. Thinking about your other STIs, and as per the management guidelines. So for instance, if there is MSM, we may be offering as well throat and anal swabs depending on sexual practices, at EGFR at 3 months and then every 6 months, and also at baseline. And then your urine protein creatinine ratio, because we want to be checking your kidney function, particularly for Truvada, and then pregnancy test for women of childbearing age at baseline. So these are some good tests that you would do to begin with, and then their scripts last for 3 months, so they come back every 3 months, have their sexual health checkup, and do the sexual health testing, and then you approve the next streamlined 3-month script after that. And we can look at all ending HIV together. So we'll stop there. We've still got a couple of minutes left to ask any questions. And thanks, Sydney. I've just seen that we've popped the Slido in as well. And Kelly asks, has restrictions on greater than 18-year-olds now been removed for PrEP? That is a really good question, Kelly. I don't know. I will look that up. Gordon, do you know? Maybe you might know.
Hello. Yes, this is Gordon here, and unfortunately, I don't believe I've heard anything about that yet. But so therefore, I think it's a case-by-case basis, and you can use it off-label. It is, I believe, deemed to be safe as per our local sexual health clinic, but you need to actually go through the sexual health clinic itself to get approval for that.
That's a great answer. Thanks, Gordon. We have a question about genital herpes. Is it always sexually transmitted, or can patient get because they have HSV1 cold sores? Can it be delayed in presentation? Very concerned about where she got it from. Yes, it can be delayed in presentation. So it could be that they've had exposure a long time ago, and because there could be very minimal symptoms, you may not have noticed. It could have been like an ingrown hair, 20 years ago, and that really be the ulceration. So a lot of people, you don't know where it's come from, and it could be that they're with a partner for many, many years. It's not that that partner has been unfaithful. It could be that it was exposed a long time ago. The thing is, we don't, no tests, no blood tests, and no swab tells us the timeline. And I guess if it's HSV1, it could be transmitted from oral to, so I guess, yeah, transmission wise, it could have been from a long time ago, yes. And she reported not having it before. She may not know that she has it before. 75% of people don't know that they have it. Yeah, good question. Always swab. Had patients diagnosed as recurrent shingles and it was HSV. Absolutely. And often now, even my lab starts that when you swab for shingles, it actually comes up with a HSV line from the lab. Georgia, does your lab do that as well?
Yeah. Yes, it does. So you have the whole line there. Yeah. But I've had like 60-year-olds, they get recurrent shingles on their buttocks. They haven't had a partner for a while, and yeah, it came back as as HSV. So
Yeah,
you can get HSV anywhere on the body.
exactly. Now, I'll see if I can stop sharing so that I can see your lovely
Nadia,
faces.
can I ask you a question?
Absolutely.
So where
Thank
do
you,
you
Nadia.
work?
That was amazing. And any final questions, or you can show your faces if you like.
So, Nadia, where do you work?
Oh, I'm in Sydney. I'm down in I'm in Ultimo. So I'm not on the coast, unfortunately. Would love to be on the coast, but very jealous of your beaches.
Right. So I just want to tell everyone I'm a HIV prescriber. I'm at Erina, but because Central Coast doesn't have too many HIV patients, I just have only 2 patients a year. So I just want to ask all the GPs, if you do have an HIV patient, feel free to refer to me rather than to the HIV clinic or somewhere else, so that because I want to keep my HIV accreditation going. And with 2 patients a year, it's a little bit not stimulating. Like, you need to see at least about 10 patients a year where you can, you can keep up your skills and knowledge. So I just want to tell everyone, unfortunately, all the HIV patients are around Darlinghurst. So when I used to work in Marrickville, I used to see quite a few of them. But unfortunately, the demographics of HIV is a little bit different in this country, in this state, everywhere else. I think it's a disease that is due to its various, associationships. Patients are, only in one certain location. And I've even reached out to the Newcastle John Hunter HIV specialist, and they tell me if I have a single one in Central Coast, I'll be referring to you. But so I just thought I'll use this opportunity to tell everyone that I'm a prescriber. I'll be happy to look after them. Yeah. So thanks a lot.
That's really helpful. This is what's great about the local knowledge. And could you pop your name, and I just can't see your face. Could you pop your name and your practice in the chat box for us all to share?
Oh.
And as I say, I know sexual health clinics are always happy to do a share care arrangement as well. So I've had patients in the past that they manage together if you've got any tricky questions.
Absolutely. Any other questions? Well, thanks so much for joining us today.
Yeah, we had some great feedback coming through, like privately, just saying that was wonderful. So really good job. And the only other reminders again, so this is our last session until the 16th of August. So we will all have a nice, well-deserved little break, enjoy the school holidays. And then Georgia, she may know our topic coming back to it, but we are working on a topic. And as soon as we have those, we will send them out to you. You will not need to re-register for our upcoming sessions. We'll just start adding the dates, so you will get reminders for those. And again, if you weren't here at the beginning of the session, we have our GP Registered dinner on the 31st of August. So mark the date in your calendar. It'll be a nice event. And anything else from Jiminy or Georgia?
No, that's great. Have a nice little winter break, and we'll see you in August. And we'll hopefully get some new registrars that are starting the terms as well. So it'll be nice to see some new faces and names there as well. But yeah, thanks for coming along, and we'll see you soon. And thank you again, Nadia.
Stay warm. Take care.
Thanks, guys.
Bye.
Bye.